All right. Welcome to Quarantine Clinics Day 8. Today we'll be discussing approach to a case of cerebellar dysfunction. So what have we finished till now? We finished overall discussion of neuroanatomy. We finished how to approach a case of stroke and hemiparesis. We finished discussing how to approach a case of quadriparesis and paraparesis. We discussed approach to neuropathy, and we discussed approach to myopathy. So today we'll be looking at cerebellum. So let's see, where is the cerebellum? So this is the brain, and this is the brainstem, and this is the spinal cord. So the cerebellum is behind the brain and the spinal cord. Okay, so it is in this area. And the function of cerebellum is to maintain balance and coordination. So coordination of what? Basically coordination of any movement. Okay, so any and all movement that happens in your body, the cerebellum will coordinate it. So if there is no cerebellum, that movement will happen, but it is not going to be a coordinated movement. That is, in layman's terms, it will not be a graceful movement. So think of all the movements that happen in your body. So when we open our eyes, our eyelids are moving. When we are looking, our eyes are moving. When we are speaking, our vocal cords, our facial muscles are moving. When we are walking, our trunk muscles, our legs are moving. When we reach for something, our hands are moving. So all of this movement will suffer if there is a problem with the cerebellum. Okay, so this is the overview of it. Now, suppose something is wrong with the cerebellum, then how do we approach the case? So we approach it in the where, what, and why pattern. Okay. Now, here we are going backwards. So now we have already assumed that there is something wrong with the cerebellum. So we already know where is the lesion. But if a patient comes to you, then what all will the patient have that will make you think that the cerebellum is the problem? So we will start from the top and go down, and we'll think of all the places that I just described where you will be moving. And you can imagine that if the cerebellum is gone, these are the areas where the patient will have some form of deficit. So from the top, let's take the eyes. Okay. And if the cerebellum is gone, there will be nystagmus. Okay. So when the eyes are turned into one side, when you're looking onto one side, you will not be able to keep the eyes in that direction. There will be continuous fluttering of the eyes in the opposite direction. So it is what the type of nystagmus that will be there in a cerebellar case is a gaze evoked nystagmus. So what that means is that if you gaze onto one side, there will be a nystagmus. If you're looking straight ahead, usually there is no nystagmus. Now there are exceptions to the rule, but for the sake of this discussion, a gaze evoked nystagmus is what you get in a cerebellar case. Second, your neck is being maintained in a particular position because of muscle contraction. So in a way, that itself is a movement. So if your cerebellum is damaged, you will not know how to maintain your head in a fixed plane. So what will happen is that your head will start moving forward and backward, and that is called titubation. So it is a continuous forward and backward movement of your head, which can be seen in a cerebellar case. What happens to your speech? So your speech is also a kind of movement. So we are pronouncing syllables one after the other. So that is how your speech comes out in a flow. So if your cerebellum is damaged, your syllables will not link to each other smoothly. So all the syllables will come out, just like all the movement will come out, but the grace is gone. So the connection is gone. So what will happen is that, suppose we take each syllable. So if I want to say constitution, okay. Now, what are the syllables in constitution? There is con, sti, tu, shun. So what will happen is that each of these syllables will be spoken separately, and there is an effort to take out each syllable. So what this is known as scanning speech. So instead of you saying constitution as one word, you will say con, ti, tu, shun, because each one of those syllables will require separate effort. So that is called as scanning speech. And another part of speech is your prosody. So what is prosody? Prosody is the musical quality of your speech. So it is what we call as the tone of your speech. So when we say mind your tone, what we are actually saying is mind your prosody. So for example, when we ask a question, we tend to leave the tone a little higher up. You get it? So when we say you get it, you end that tone in a slightly higher pitch. So the right part of your brain actually controls your prosody, but without your cerebellum, you are not able to uh, control the volume of your speech or the tone of your speech. So suppose there is something wrong with the volume of your speech, you get something known as staccato speech. So when we are normally talking, we are able to modulate the tone and the volume as we want. But in a cerebellar case, your volume might suddenly go up or it might suddenly come down. And so you can have a speech that sounds something like very loud and then suddenly very small and then very quiet words and then again very loud words. So it is not a smooth modulation of a voice. It can be very irregular and jarring to hear. So that is called as staccato speech. Now coming to your limbs, you can have intention tremor. So what does intention tremor mean? Now imagine that there is a cup in front of you, okay? And you want to reach that cup. What will happen is your brain is trying to calculate the distance between you and the cup, the angle to which your arm should be raised, and the force and speed with which your arm should approach the cup. Now, as you move your hand closer and closer to the cup, the calculations will keep changing. And when you are almost at the cup, the calculations have to be done in a very fine way. So you have to continuously adjust the distance of your arm and your fingers to the cup. So as you reach closer to your target, the amount of calculation required is more. So in such a time, when your cerebellum is not working, you can have something like a hang up. Your brain is trying to calculate, but the cerebellum is not there. So your brain can go further and then backward, further and backward. And if this thing happens very rapidly, you get what is called as intention tremor. So intention tremor is when you approach a target and your hands start to shiver, and if there is a tremor, then that is called as intention tremor. So coming to the same example, suppose you are not able to calculate the distance properly. What might happen is that if this is the cup and if this is your hand might stop here, which is called undershooting, or your hand might overshoot. So it might cross the cup and go. So that is called overshooting. And what this leads to is dysmetria. Dysmetria means inability to calculate the distance or meter. So inability to calculate the distance is dysmetria. So there is undershooting and overshooting. Okay. Next is dysdiadokinesia. So what does this mean? Dysdiadokinesia is when you cannot do rapid alternating movements. So if you want to say take a chapati and put it on the other side and then put it back and then on the other side, that alternating movement requires your cerebellum to function properly. So in a case of cerebellar dysfunction, you are unable to do alternating movements. So that is called dysdiadokinesia. What else can be there in your hands or your limbs? You have something called dyssynergia. Okay. Now, what is dyssynergia? So what is synergy? So let's remove all the distance and angle and all that. Okay. Now, again, coming back to the same example, if you want to lift a cup, now your arm consists of your shoulder joint, your elbow joint, your wrist joint, and it consists of all your phalanges, so interphalangeal joints. So you have all these multiple joints that have to function in a flow in order for you to stretch your arm and grasp the cup and then lift it up. So all those joints have to function one after the other and smoothly for your that whole movement to happen gracefully. Okay. So if this movement, so first your shoulder has to move, then your elbow has to move, then your wrist has to move. If this sequence of joint movement is lost, what would happen is sometimes your elbow might move first and then your shoulder, or your fingers might grasp first and then you will extend your hand because that sequence is lost. In that case, you get dyssynergia. Okay. So usually the sequence is not lost as much as the flow is lost. So usually your fingers will not grasp first before your elbow extends, but what will happen is that your elbow extending and then your fingers flexing, there will be a gap in time because there has to be a separate order because your cerebellum is not there to make it into a smooth flow. So that is dyssynergia. What happens in your trunk? So you have truncal ataxia. Okay. Now, what is ataxia? Hang on. So, what is ataxia? Ataxia is inability to maintain coordination. And this mainly refers to maintaining balance. So if you are unable to maintain balance, you will have ataxia. Now, ataxia does not equate to a cerebellar problem. You can have loss of balance because of multiple things. So because this is important, we'll look at it a little bit more in detail. What are the components required for you to maintain balance? So what is balance? Balance is an awareness of you and the environment and your ability to make corrections if there is any change in either your position or your environment. So supposing you are walking on a flat ground or you're just standing. So for example, suppose you're just standing on the ground, you need to know whether your legs are extended or they're flexed. You need to know if you are upright. You need to know if your trunk is upright. You need to know if your head is upright. Okay. And when you are walking, you need to be able to continuously adjust your hip, your knee, your ankle positions. You need to adjust your trunk position so that you maintain your balance. Which is why in a ship, for example, if you are standing in a ship and the boat is rocking up and down, a lot of people may lose their balance because the ground is moving. Initially, your brain is not able to calculate it quickly enough. Okay. Now, what are the parts of your body that helps you keep balance? So one is a sensory system. So you need to know where your joints are. So your joint position sense, which if you remember, goes through your large nerves. And then if you remember, enters your spinal cord in your posterior column. Okay. So if there is any issue with your large fibers or if there's any issue with your posterior column, you get what is called as sensory ataxia. Okay. So a sensory ataxia is you have imbalance, you have ataxia, but the ataxia is because you are not getting enough information from the ground or from your periphery for you to make an informed decision as to how to stand, how to walk. So if you don't know, then how do you decide? So that is sensory ataxia. Suppose there is nothing wrong with your sensory system. Suppose your joint position sense is normal, your posterior column is normal, you're getting all the information you need. So where does that information go? There is in your brain stem, there is something called as vestibular organ. Okay. So the vestibular organ is actually in your ear and your vestibular nuclei are in your brain stem. And the vestibular nuclei is mainly involved in a sense of balance, because all the information of whether your head is straight or turned, if your body is straight or turned, all that information is controlled by your vestibular organ. So if your vestibular organ is gone, you will get imbalance with vertigo. So whenever a patient says, I have vertigo, if the world is spinning or I feel like the entire world is going round and round, then that means something is wrong with your vestibular system. So that can also lead to imbalance. And finally, suppose your vestibular system is normal, finally, there may be something wrong with your cerebellum. Okay. So cerebellum is basically in charge of your output, your motor system. So your sensory system is normal. You are getting good information from the periphery. Your vestibule is also normal. So your inherent sense of balance is good. And but your cerebellum is not able to convey the right information back. So when you are trying to walk, your limbs are not being graceful. So when you're walking, there is imbalance because your limbs are not able to coordinate the movement. So cerebellum is a sort of outflow ataxia. So nothing is wrong with the inflow, but your outflow has a problem. So you have ataxia. So that is called a cerebellar ataxia. All right. Now, coming back to this, you can have truncal ataxia or you can have cerebellar ataxia. And finally, in your lower limbs, again, you can have ataxia, and you can also have in your limbs, you can have hypotonia. Okay. And you can have pendular knee reflex. So your knee reflex can be more sustained. Now, these are the characteristic features that you will look for in a patient that will make you think, where is the lesion? It will make you think that the lesion might be in the cerebellum. Now, let me just see if I've missed anything. Nystagmus, titubation, intention, tremor. So one of the most important things to look for in a case of cerebellum is gait. Okay. So we spoke about this in our first lecture, how gait utilizes almost every part of your nervous system. So a gait, watching somebody walk is a great way for you to come to a diagnosis, because if there's something wrong in your cortex, in your brainstem, in your cerebellum, each one of these dysfunctions can lead to a very different kind of gait. So specifically in the case of cerebellar dysfunction, the characteristics of the gait will be that there will be swaying. So the patient will sway like a drunk person. Okay, so that is very specific for cerebellar gait. The patient will sway like a drunk person, and usually if there is one-sided cerebellar problem, the swaying will be towards that side. Second, it will be a wide-based. So your feet will be spread apart from each other, and you can have abnormal tandem gait. So tandem gait is essentially when you are walking by keeping one foot directly in contact with the next. Okay, and you're supposed to walk in a straight line, and you're supposed to keep each foot in contact with the next. And usually by the time you walk around 8 steps, if 2 or more come out of this line, then that means it is a abnormal test. And this is quite sensitive, and a tandem gait is quite sensitive to pick up a cerebellar lesion, or at least tell you that there is a gait problem, and then you can evaluate specifically for a cerebellar lesion. And one more thing that I would like to cover is Romberg sign. So in Romberg sign, what you do is you ask the patient to stand, keeping both feet close together, and you can keep the hand stretched out in front. Okay. So in this case, what will happen is that the patient will require a greater sense of balance if your 2 feet are close together than if they are spread out wide. And suppose, like we said, for you to maintain your balance, you need input from your sensory system, and you need output from your cerebellum for you to coordinate. Now, suppose your sensory input is gone, but you still have your eyes open. So using your open eyes, you are able to see that you are standing upright, and you're able to see where you are. So using the information given to you from your eyes, your sensory system compensates for your lack of sensory input from your limbs. So even if your joint position sense is gone, the sensory input from your eyes will compensate for that. And so you may be able to maintain your balance. But suppose you close your eyes, or you ask the patient to close his eyes, then this compensation is gone, and then you have ataxia. So the patient will have imbalance. So it's very important when you ask them to close their eyes that you keep a hand near them so that in case they have a imbalance, you're able to catch them, because they should never fall when you're doing a Romberg sign. Similarly, for tandem gait, you should always remain close to them so that they don't fall. Now, this is in case of sensory problem. What if your sensory system is normal, okay, and it is a cerebellar problem? So then, even if your eyes are open and your sensory system is normal, your brain is able to judge exactly where you are. So the brain knows how to maintain the balance, but it is your final outflow that is gone. So in a case of cerebellar ataxia, even if eyes are open, even with open eyes, there will be ataxia. Okay. So a Romberg test is said to be positive when on closing eyes, there is imbalance. And a positive Romberg is a sign of sensory ataxia. So a Romberg is not actually something that you look for in a cerebellar case, because a positive Romberg is a sign of sensory ataxia. All right, so I think that is all there is to localize the lesion to the cerebellum. Within the cerebellum, there are different anatomical areas. So there is a central Vermean cerebellum, and then there is lateral hemispheres. So basically, it follows the body anatomy. So the central part of cerebellum is in charge of your trunk and your core muscles, and your lateral hemispheres of the cerebellum are in charge of your hands and peripheral appendages. So now we shall look at the anatomy for a bit. So I've already drawn this and kept. So this is your brainstem here. Okay, and this is the cerebellum behind the brainstem. And in the cerebellum, as you can see, there is an anterior lobe, there is a posterior lobe, and there's something called as the flocculonodular lobe. Now, in this, the flocculonodular lobe is more phylogenetically ancient. And looking at it from the anterior view, so we are looking at it now from this aspect, you can see that in the center, there is something called as vermis. Okay, so this is vermis. And then on both sides, you have the hemispheres. So the vermis is responsible for the trunk and maintaining your core balance. Whereas the hemispheres are responsible for all your limb features. So your hands and your legs, so all your dysmetria, intention tremor, all of that comes from your lateral hemispheres. And there are nuclei inside the cerebellum. So it's just important to know this. There is the deep nuclei, which is called dentate, emboliform, globus, and fastigial. So this is just a little bit about the anatomy of cerebellum, and the basic molecular structure is that in the cerebellum, the input will come from here. It will go to the superficial part, and from the superficial part, it will go to the deep nuclei, and from the deep nuclei, there will be an output. Okay, so roughly, this is the structure of the cerebellum. Now, I have a diagram here that shows in more detail what is the structure, but this is only important from a theoretical sense if you get a long answer question of structure of cerebellum. But briefly, it's just important for you to know that there is a superficial layer and a deep layer, and there's an input into the superficial layer, and the output is from the deep layer. Okay. Now, coming to, so we have finished where is the lesion. Now coming to what is the lesion. And when we talk of what, here ODP is very, very important. And in this, onset is probably the most important. So onset and duration. So after ODP, what you want to know is the cerebellar ataxia acute or was it chronic? So did it happen over a few minutes or over a few days or a few months or a few years? Did the patient have the symptoms of ataxia since many years or a few days now? That makes all the difference in your diagnosis, because remember your vitamins etiology mnemonic, where V is vascular, I is infection, then trauma, autoimmune, metabolic, iatrogenic, that is drugs, nutritional, and syndromic, that is hereditary. Now, in all of this, there may be some acute causes and some chronic causes. So the way that you think about this as you go forwards is, one, is it acute or chronic? And two, is it acquired or hereditary? Sorry, I should have, hold on. Yeah. So is it acquired or is it hereditary? Okay. So this is the rough way in which you divide it. So you have acute and chronic, and you have acquired and hereditary. So within acquired, you have all this, the whole vitamin. So that is how you divide the causes of cerebellar ataxia. And I won't go too much into detail further in this. That is something that you can look up, and you can fill this chart on your own. And that will be a good revision for you as well. And we can discuss this tomorrow. Roughly, the causes will remain the same as the ones that we discussed previously. So vascular, you can have stroke, infection, you can have all your tuberculosis, or you can have meningitis or meningoencephalitis, any trauma, usually acute, but could be a chronic trauma. Autoimmune could be multiple sclerosis, or could be could be a chronic or an acute autoimmune encephalitis. Metabolic, such as nutritional deficiencies, drugs that can cause acute and chronic ataxia, and syndromic, that is your hereditary causes in both. So hereditary causes are usually always chronic, because it's unlikely that a hereditary cause will present acutely. But in your hereditary causes, you can further divide it by, is it autosomal dominant or autosomal recessive? So that is a further classification that you can do to help you evaluate it further. And this will come from your family history. So in any cerebellar case, in fact, in any neurology case, it's very important to draw a family tree. And your family tree has to be at least 3 generations. Okay, so 3G. It has to be at least 3 generations for you to figure out if it is autosomal recessive or autosomal dominant. And suppose there is a family history, then it might need to be even more. It might need to be 5 or 6 generations sometimes. So that comes to your that covers your where, the what, and the why. Coming to investigations, it will depend completely on your cause. So your main investigations will be your MRI and your blood tests, specifically targeting whether there is an infection, whether there's an autoimmune cause, if there are any drugs, so you can do drug levels. If there's a nutritional deficiency, you can do vitamin levels. And if there's a syndromic problem, then you can do your genetic screening. Now, there are a couple of things that I had stored previously, but again, this is all theoretical. This is a more in-depth detailed diagram of the input and output connections within your cerebellum. So here you have your input that will go to your superficial level, and then from the superficial level, it will come down to the deep level where there is an output, and then it will come out. Okay, so this is roughly how the deep connections inside the cerebellum are. And finally, I wanted to just briefly touch upon the connections between the cerebellum and the rest of the brain. So let's look at the neuroanatomy once more. Okay, and here is the cerebellum. So as you know, there are incoming tracts, so ascending tracts, and there are exiting tracts called descending tracts. So that is to and from the brain. Similarly, there are tracts which enter the cerebellum, and there are tracts which exit the cerebellum. All right. So there are 3 doors in which you can enter and exit the cerebellum. Each door is called a cerebellar peduncle. And the names of the doors are superior, middle, and inferior cerebellar peduncle. So through each one of those doors, there are certain fibers that go in and certain fibers that come out. Okay, go in, come out, go in, come out. So through each one of these doors, there are incoming tracts and exiting tracts. So that is what this is. So the afferent fibers are incoming, and the efferent ones are exiting. Okay. So, and this is the superior cerebellar peduncle, this is the middle cerebellar peduncle, and this is the inferior cerebellar peduncle. Now, again, this is not completely for theory, because supposing there is a middle cerebellar peduncle damage exclusively, and your cerebellum itself is spared, but your middle cerebellar peduncle is gone, then your pontocerebellar tract will be gone. So you do need to know which cerebellar peduncle contains what, but roughly this is the overview, and it is actually sufficient for you to diagnose that there is a cerebellar problem. And once you diagnose that, then you can go ahead, do an MRI, and see if is it a core cerebellar issue or is it a peduncle issue. Okay, so yeah, so that's the rough outline of that. And this is another picture that I had copied and kept because this is the 2 incoming tracts. So there are only 2 fibers that carry information into the cerebellum. One is called the mossy fiber and the other is called the climbing fiber. So all the information that enters the cerebellum enters through one of these 2 fibers. Okay. And finally, there is in your spinal cord, there is something called as the Spinocerebellar Tract. Okay. So as per the name, the Spinocerebellar Tract is the tract that carries information from the spine up to the cerebellum. So it is an ascending tract. Okay. And what this does is that it carries information from your muscles. So because the cerebellum is involved in controlling muscle, so it is involved in making your muscle movements smooth, there is a separate tract directly dedicated for your muscles to talk to the cerebellum, so that the cerebellum is in continuous contact with the muscle. So that is just an extra information for you to have. So the spinocerebellar tract basically carries feedback from the muscle to the cerebellum. And that's all you need to know about that. And finally, a brief note on what else the cerebellum does apart from controlling movement. So this is something that I was personally interested in, that it also controls your language. We already spoke about that. It controls your tone, it controls your prosody. Cerebellum is very, very important in music. It helps you both listen to music, it helps you listen to the rhythm of the music, and it helps you create music. So when you're singing, or especially when you're dancing, cerebellum controls whether are you able to keep the tone, and are you able to keep the pitch, and are you able to keep rhythm. So there are some people who are horrible singers and some people who are naturally very good singers, and they're able to keep the rhythm. So in them, maybe there is your cerebellum isn't focusing on the music enough. This we'll actually be talking about in much greater detail this Sunday, because in this Sunday evening we'll be discussing music, just like we discussed memory last Sunday. This Sunday we'll be discussing music. So I'll explain this aspect of music much more then. Uh, Cerebellum is also involved in memory, especially your procedural memory. So when they say that once you learn to ride a cycle, you don't forget, the reason you don't forget is because a part of that information is stored in your cerebellum. So your cerebellum remembers how to ride a cycle once you learn it. So it doesn't have to calculate every time how much pressure to apply and how do you maintain your balance. So once it learns, then it will just store it as a separate file. So whenever you start cycling, it will just upload that file and it will start cycling. And it also plays a very big role in cognition. So how do you organize your thoughts? So just like gracefulness in movement, there is gracefulness in thought. So some people are able to think in a flow and it's very smooth, and some people think very haphazardly, or they think a lot for a while and then they lose their flow of thought. So that flow of thought, it's believed that your cerebellum plays a role in that. So yeah, I think that's about it. Cerebellum is actually a small topic, but it's very interesting, and sometimes diagnosis can be challenging. So I hope that this clinic helps you with diagnosis. And now, if there are any questions that you want to ask, you can ask in the chat. No questions. So then, so this actually completes. This actually completes the first set of clinics that I wanted to take. So I wanted to give an overview of the entire neuroanatomy and how to approach the main cases that you'll be getting in your exams, and even the main cases you'll be getting in your practice. So this actually completes that. Now, the next series of clinics that I'll be taking is going to be a little more targeted towards neurology residents, which is going to be electrophysiology. So that will be for 3 days. And tomorrow, I'm not going to be taking anything. So I'll probably start from Wednesday or Thursday. And Thursday, Friday, Saturday, I might take electrophysiology. So the basic cases, again, if there are specific cases that you want me to take, please let me know so that I can plan it, and we'll take it from next Monday onwards. If you are interested in electrophysiology, you are more than welcome to join in. It will be at 7 o'clock. The password will be the same, and I'll be putting it up on Twitter and Facebook, and you are more than welcome to join in. It might be useful because I'll be discussing how the muscle works and how we take electric reading from the muscle. But from a practical sense, it will be useful if you're doing neurology or if you're doing electrophysiology. So, okay, so there's a question: what is hot potato speech, and how is it different from the two speeches discussed? So, hot potato speech is generally considered to be secondary to a more local cause, a local lesion. Okay, so hot potato speech is usually when there is some sort of either like a pharyngeal abscess, or there may be a tongue lesion, or there may be something preventing you from articulating clearly. So usually hot potato speech is reserved for that. We don't use hot potato speech in a case of cerebellar dysarthria. Okay. Cerebellar dysarthria, in cerebellar dysarthria, the individual syllables are normal. Okay. So just like in your limb movement, the individual movements are normal, but the flow is gone. Similarly, in cerebellar speech, the individual syllables are normal, but the linking up is the problem. So there is dyssynergy of speech. So sometimes the volume can go up and down, and each syllable is pulled apart. So there is scanning speech. So this one is also being recorded, and I'll put this one up also on YouTube. Uh, you can check out the channel. It's called Siddharth Warrior, and you can check out quarantine clinics, and it is shareable. So if you have anybody who wasn't able to attend the clinics or didn't know about it and would be interested in these clinics, then please let them know. And if there are any questions that they have, they can ask me on either Twitter or on YouTube. Bye. Take care. All the best.